Brilliant. Thanks everybody for attending this second in our summer series of webinars, lunchtime kind of learning chats with some of the people that we're working with as the Institute of General Practice Management. So it's Tuesday the 17th of August, and this is number 2 in our series. So we'd just really like to know where you are, just to make sure we're getting a good cross section of the UK. So if you could go to Menti for me. So it's MENTI using code 44220407. And you should be able to put a little dot on the map of where you are. Oh, that's good, it's working. Fabulous. I don't know whether the blue dots will work in Scotland. Ah, yes, they do. Wonderful, thank you.
Yay.
So not quite made it to Wales or Northern Ireland today, but a few people from across England and Scotland. That's great. Thanks for doing that. And if you're a bit late to us or late working the technology, you should be able to still put those details in as we go through the presentation. Just a reminder of who we are. I'm Kay, and we've got Robin with us today.
Hi, everybody.
I think Nicola might join us shortly, and Joe's on her holidays. So Robin just wanted to give us a quick update on our campaign, The Abuse Must Stop. Robin, over to you.
Yeah, so over the weekend, we were informed from the General Practice Facebook group about some incidents that happened in Gloucestershire and in Lincoln, where practices had, so one practice, the one in Gloucestershire, had blood-soaked items thrown at their receptionist by a patient. And in Lincoln, they had a bomb threat called in by a patient who was off-listed due to unreasonable demands, ironically. We just wanted to highlight again that this is still happening, and we've called on the government and on NHS England to actually give us some proper support. So we've said we want some kind of comms going out to patients to explain that we have been open the whole time, that we've done 75% of the vaccination programme, that we are still seeing patients, and that a telephone consult or a video consultation is still an appointment. Just because it's not face-to-face doesn't mean that it's not as good a service, but also the reasons why we have to work the way we are working. So I'm hoping that a lot of you have seen that on Twitter and on Facebook. Feel free to share it, retweet it, tag people in it, and just keep the noise going that we're trying to make.
Thanks, Robin. And just for those of you that are not under NHS England jurisdiction, our reps in Scotland, Northern Ireland and Wales will be sending that on to their respective bodies as well. We're really conscious that we're a four-nation organisation, and you will be having those same issues as us. Okay, thanks, Robin, for doing that. So, is there anything else that you can think of around that campaign that we can do? I think as a board, we're just keen that when there are any of those examples, we keep shouting them out. We keep saying this is continuing and it's got to stop. So if you are victim to anything like this, please let us know. But if you want to go to your Menti, and if you've got any ideas of anything else that we can do, please just put your ideas in Menti or in the chat, and we'll get onto those. We're also conscious there are loads of things that we could do, and loads of things that we're kind of just starting to explore. And what we need more than anything is some more members. So if you haven't paid your subs yet, or your colleagues haven't, or you could encourage your CCG to get your practice managers to join, that would be amazing.
I love that we've got go on strike versus carry on being there. Two very opposing ends of an argument.
Yeah. I think if any of us were willing to go on strike, we probably wouldn't still be working in the NHS, would we? Okay, so carry on highlighting and asking for support. Brilliant. That was our feeling. Yeah, and the next campaign that Robin's going to launch is around, if it's really well with today's session. I can't remember the title of it. Was it right
care, right time?
Right care, right time. So that will really fit in with the social prescribing that we're going to talk about next. Okay, fabulous. Thank you. Oh, it's interesting to see it was on breakfast television this morning as well, then I missed that. So our special guest today is Christy, who is the Chief Executive Officer of the National Association of Link Workers. And if you're on Twitter, you'll have definitely seen Christy all over the place. She is, you tweet lots, don't you, Christy? I'm guessing that's on a bus journey or a public transport or something.
Yes, you need to kind of like get the word out there, just like you guys. It's energy. I think we've got that energy, so we'll just keep that going.
Fabulous. So you're going to talk to us today a little bit about what your organisation does and how perhaps we can work together moving forward. And then we had quite a few questions, and I've just picked 4 of those that we can go through together. So can you tell us a little bit about the National Association of Link Workers?
Yes, absolutely. I'm really delighted to be here with you, wonderful practice managers. And I'm not a special guest. I just feel that I'm amongst colleagues and people that are doing great work, that are very much grassroots as much as we are as well. So the National Association of Link Workers is the professional membership body for social prescribing link workers. Just like the way the IGPM kind of like came about, nobody's coming to save anybody. So if you feel that something is very wrong or you're passionate about something and you want to raise awareness, you just need to come together and set something up and actually do that. So most of so we're a membership, so we do have organizations that employ social prescribing link workers, such as practice, individual practices, as well as voluntary sector, as well as primary care network, as well as health and social care partnerships. There's various models across the country. So we have members UK-wide, just like you guys have got. And what we are primarily concerned with is empowering organizations delivering social prescribing, as well as social prescribing link workers themselves, to make a success of this, so that it's not just something that is just contract, because we were there before the national rollout of social prescribing link workers within England. So very much very keen to make sure that the through ethos of kind of like social prescribing stays the same, and bringing that grassroots perspective and tools that you can actually use to make sense of it and make sure that we get those outcomes that we seek for our organizations and for our patients.
Fabulous, thank you. And certainly at my practice, so I'm practice manager at Alvanley, I think our link worker, our social prescriber, has had the most impact on our workload. And I know all kind of 50 practice managers that are on this call today, that's one of the big things for us, is to look at how we can kind of work with the demand that is in front of us at the moment, and certainly link workers can help us with that. So let's go on to a question for everybody in the audience. Have you got a social prescriber in your practice at the moment? And we'll just be able to understand a little bit more about who we've got. Great. Nobody said they don't know what it is yet. It's funny, isn't it, Christy, that there are so many different names for the same thing?
Yeah, I mean, social prescriber and social prescribing link worker would do.
Yeah. Great. So they're getting out there. That's lovely to see, isn't it? Not yet, but coming. Great. So first question from one of the practice managers in the IGPM. How do we find patients? So we know that there are people there that probably don't need to see a GP, but how do we identify them? Have you got any kind of quick tips or things that practices could do to identify people?
Yeah, so first of all, shout out to the social prescriber link workers that are joining us in the chat. I noticed that if you can just chip in as well, that would be great. So I think general practice provides cradle to grave care. So finding the patients, we're there, we're not going anywhere. So you're providing cradle to grave care. And I think it's by understanding the concept of social prescribing and what it's there to do. it enables general practice to offer holistic service to patients. We've all been almost consumed by the coronavirus pandemic, and people have been able to live through social prescribing and understand how these social factors affect our health. So I think it's a question of embedding it in day-to-day general practice work. So if you look at your patients list, there are people there that will benefit from social prescribing, but if you don't understand social prescribing or what the link worker does, or it's just referral, and don't understand this is about empowering and enabling people to take control of their health and well-being, building resilience into people, because if people don't have an infrastructure around them, I'm going to come back to my GP. How many times I have been to my GP, in the past when I didn't have support, immediately I'm leaving there, I want to go back and make another appointment, because it's almost like I don't want to be alone in the world. It's really, really hard. There's a lot of questions and lots of things. So if we're not building an infrastructure around the person and making sure that they're being enabled and empowered to take control of their health and well-being, so it becomes problematic. We've had some examples of some practices where they have engaged a practice nurse and the social prescribing link worker has looked at their cervical smear screening program. So every preventative public health campaign ideally should have a social prescribing offer. So they looked at that, and there were the uptake was quite low, and the work with social prescribing link workers to help to offer holistic support to some of the women that had reasons why they were not coming with some of these social determinants of health. It might be issues with transportation or things that are happening in their personal life that is preventing them. So this is how the inequalities grows, isn't it? So it is about that proactive case finding as well as opportunistic case finding. If it's something that we want to offer holistic support, we know that people are coming to us, they're not differentiating the medical and the clinical, they know something is wrong, off you go to your GP surgery. So if I see the GP or the nurse or member of the MDT team, there should be kind of like that thinking about social needs, medical needs, social need, medical needs, social need. We should not be differentiating both. So what I would say is embedding it and making sure that every member of the practice team understands their social prescribing, and that through the part of the consultation is actually a service that can be offered. And now we've got somebody that can help with that bit. And most of the GPs tell me that it helps them to actually make better clinical decisions and actually have that consultation focused, because when a patient comes with a lot of things that is going on and you've only got 10 minutes to attend to that, it almost feels like patched up, and then you leave and you feel like you're not, all your problems have not been sorted. So first of all is actually understanding what social prescribing link worker does, looking at your day-to-day activities within the practice and how can you utilize and embed social prescribing into this, that will help you with your cough point. How can this also help people that are being discharged, because then we're also having some thematic link workers that are looking at the cancer pathway. So we have then a range of ways to utilize social prescribing, but it starts with understanding that this is about offering holistic support to your patient and empowering them and being in an infrastructure and not encouraging a dependency culture. Otherwise, this is what is increasing the demand, because they don't have infrastructure around them. And then looking at the proactive case finding and looking at your practice list about those that can benefit as well.
Okay, so really thinking about what the problem is or what the issues are in your practice and helping social prescribers to help you find a solution. So if you've got low uptake rate for smears or any of the other, breast screening, bowel cancer screening, or like me, my issue was we had a cohort of patients who kept coming back and coming back and coming back. So we just ran a report on that number, and straight away we'd got a cohort of patients that our link worker could see. Fabulous. There's some really good ideas. I hadn't thought about the linking them with the chronic disease management. Great.
Julie in the chat is also flagged up that getting your receptionists involved, because they often speak to patients who are high users of services who are constantly coming back, and they can feed into the social prescriber to look at patients who might need that extra bit of support.
Yeah, I think that's really true, isn't it? They have almost a better insight on the behaviours of people rather than that 10 minutes that a GP might have. Okay, so how can we persuade patients to see somebody else in the practice team, so the link worker? Is that again about describing it a bit better?
Yeah, I think that question, what we're actually finding in most areas is actually a waiting list being operated for social prescribing link workers. And this is, the pandemic has helped, both the clinical teams and as well as patients themselves to kind of like understand the concept of the social factors and the need for us to be a bit more resilient and kind of like self-care. You need to stand up and brush your teeth in the morning and dress for bed, those sort of like things, and realizing that medical solution isn't always, because the COVID is only recently we managed to get a vaccination. So that kind of like concept of the social aspect and the need to self-care and the need to have the community to actually help to sustain that. So people are recognizing that that is part of treatment kind of like package is all of those things. So what we're finding is actually more kind of like waiting list and pressure on social prescribing link workers in some areas that are actually recruiting more and more. But I think that some of the areas where maybe they are trying to also expand access by including self-referrals, then that is where the embedding at every level within the practice is very paramount, and that being reinforced. So there was a practice manager that spoke at our conference last year, and literally what she did before today's service was introduced is to make sure that the GP receptionists, the nurses, the doctors, so everybody within the practice team was embedded, bought into this idea, understood that, so that the same way you're introducing a new service, it's the same way the social prescribing is a new service. So everybody's involved with that marketing and that patient education, and people are coming up with ideas of putting that, within the waiting area, within the screen, and actually having the GPs themselves being on camera and saying, this is how we do things in this practice and all of that. And also remember that we had a GP forward view where we had a 10 high impact actions to release capacity, where we had active signposting, where what is meant to do was to upskill our GP receptionists. I was very much involved in Cambridgeshire and Peterborough for that rollout, help them with the rollout of the active signposting, so that everybody's asking a question and people understand they need to ask a question. So if sort of like patients are used to, being asked the reason for the appointment and understanding that these people are not, they're care navigators, not receptionists really, is to get you to the right clinician, then, it becomes less of a struggle. And I think that this particular question also will relate to, it's historic, isn't it? It's just the same thing with as well, and also members of the MDTs that is being introduced. But I think it's for everyone within the practice team to reinforce that, and even when they manage to get through to the doctor will still reinforce the need for this person seeing you now, because at the end of the day, I don't know the access to the support within the community that you can get, and also your problem is social, and I've only got 10 minutes to give you.
Yeah, that's right. So as soon as they know that somebody's got half an hour or an hour to spend with them, then that's a real winner, isn't it? Okay, thank you. So what are we on next? Does it always have to be face-to-face? Does it always have to be a patient and a link worker sat in a consulting room? Are there different models?
This is the beauty of social prescribing, and I think this is exciting for all non-clinical roles as well, is where there is flexibility, isn't it? So it is very different to other clinical roles where it's kind of like 10 minutes, 15 minutes, you sit down there. No, you can have walk and talk appointments. There are innovative ways that the social prescribing link workers are employing. Remember that they don't also have to be based in the practice. There are some, of course, things that are opening up now, but before, the pandemic, you have people, you can meet them in the library, the community cafe, various areas where you can have that first appointment. Because the beauty of this lies within that relationship, because you need to build trust with the person and maintain it. That's what enables them to open up. And it's just really, really harrowing to hear some of the stories that, some people, they've been kind of like abused for like over 20, 30 years, horrific things they've been through and they've never told anybody about it. But it's actually that relationship and that trust that you're not coming to take the benefit away from them. You don't have any agenda. The only agenda you have sort of the person. That then helps us to understand what's going on. What's going on within our patient population list. So it's the flexibility that introduces, but one of the things that I would appeal is to see them, they are professionals. So of course, sometimes they do need a consultation room, for a few hours. It might not be, kind of like a permanent day, but also accord them that flexibility. And this is the reason why they need to have laptops and need to have mobile phones and all of that, because the nature of the role is not structured to be the same kind of like same old, because otherwise there's nothing disruptive about it.
Yeah. Yeah, that's interesting. Interesting view as well. Just thinking about how we have started to develop this. We have group consultations now with our social prescriber. So because he knows a group of people who've all got the same issues, he's brought them together, and then that adds to their resilience as well. Lots of telephone calls over the pandemic, but really there are lots of ways of making sure that they're embedded in our practice teams. And I'm sure those on the call now have got lots of ideas. Have we seen somebody said ours will meet patients in a cafe during their lunch break? So that's really good, isn't it? But great flexibility shown from that group of workers. So inappropriate and appropriate referrals. It's really difficult, isn't it, sometimes when you've got, certainly in my experience, we've got patients that come back and back and back and back, and actually it's not a medical problem. So are social prescribers looking at non-medical problems? What is inappropriate for a social prescriber?
I think that this is continuous education. Again, what we do at the National Association of Link Workers, we've got our code of practice, we've got an employer's guide, we've got tools that we try to set the baseline of what they should be doing. So they are not counselors, they are not befrienders, they are not a mental health specialist, they are not, they are not, what else can I say? They're not medically trained, they are not clinicians. So I understand kind of like the depression. Sometimes you might recruit a social prescribing link worker that has got a nursing background. What you need to actually understand is about setting up the rest failure, because then if you're pushing in, prescription for an eye or things that is somebody that has to be medically qualified that is doing that, it's actually taking away, again, it's increasing inequalities by taking away the support, which this role was created because there was a clear need. There was 20% of GP appointments for these social issues. And we know that, I would argue that inequalities is what is driving the demand in general practice, because when I was just so broke, I'm not trying to put anybody down, but there's a time I was so broke, and the first thing I'll think about is my GP, because I know, I'm not saying it's free, but I know at least I'm gonna get through. So inequalities and some of this not knowing what to do and that lack of support is what is driving all the demand. So and if we're not getting these inappropriate referrals and we're not actually logging them, then how can we say we need a resource for that? And we're just kind of like going round and round in circles again. So what most people say to me is that, this is quite fairly new. They're not very clear on what they do and not, and also to send the referrals back. But what we need to do is to make sure that we empower the social prescribing link workers so that they feel confident and not feeling like they're not kind of like part of the team, or breaking the team spirit by actually having to send these referrals back. But human beings have got the solutions to all these problems. Let's just get the receptionists and the GPs and social prescribing link workers together in a room, and let's sort out that pathway. Because we do need an integrated pathway. It's not just the social prescribing link workers, because now what we're hearing is that care coordinator is like, hello, I've arrived. Hello, what am I doing? So it's just kind of like, what's going on here? It's good to have 20,000 people joining the practice. But if we're not kind of like utilizing them appropriately, and it's just, yes, where's our money? Let's go and get our money. Investment and impact fund. Yes, let's increase the referral. But if you're not getting the outcome that you actually see within the practice and the patient, it's not good for you. So I think this actually requires a bit of a team-based working to actually sit down, look at the pathway, and not only looking at this from a point of view of social prescriber, actually looking at this from a personalized, integrated pathway, because now you have care coordinators and all the members of the MDT team that are joining in, and just making sure that we're very clear and so that people that should benefit from a service are not being defranchised because we are just under pressure on sending in lots of inappropriate referrals, and empowering the workforce and the social prescribing link workers feel part of the team and feel like they can actually raise these things without feeling like they're not, team player.
So investment at the beginning, get to know what they can do, what they can't do, link them up with everybody in the team. So, we've got physiotherapists in some practices now, we've got pharmacists. We our receptionist role is much more of a patient advocate, isn't it, than a receptionist. So any effort we put in at the beginning will reap huge rewards. Okay, just wanted to give you a minute just to talk about your link work a day, and specifically how could we help with that? What could we do? Do we
That is your next campaign. Come on, practice managers. We have got Link Worker Day 2021 coming up. You can see the hashtag there. I wanted to blast it across the surgery, ignite the patients, tell them, you know, this is an opportunity to raise awareness. You're looking for something to do. So it's not just, you know, saying the practices are locked or anything. Go and message your patients and say, hey, there's an exciting thing that is coming in here. And do you know about social prescribing? And you feeling isolated or lonely? Do you feel like you want to catch up, make friends? You know, things like that. Get them involved, and they can actually, you know, want to do posters or things to raise awareness. So we definitely need practice managers behind this, because I really, really think the practice managers and social prescribing link workers working closely together, they are the creative disruption that we need. So if you go onto our website, nalwevents.org, we have got information about how you can participate. Social Prescribing Link Worker Day 2021. We've got a conference coming up, and within the conference, we're going to showcase inclusion health approaches. So if you're interested in having specialist social prescribing link workers, because you know we need to get rid of inequalities as much as we can. Are you with me on that? So we have got a showcase, the workshop for that. We have got some fantastic GPs that are going to be speaking about team-based working. So I we really need your support. So let's go and get them and get involved in Link Worker Day 2021. And we've got a couple of free, I think, tickets, don't we, Kay? For a few people. And then the rest, of course, you can nag them to pay, nag your practice to pay for.
Will you just say your website again? Was it www.na?
Yeah, so we've got two websites. So if you go to nalw.org.uk, that's our membership website. And Fabulous. If you scroll down to the bottom of the events, you can see. So Robin has put that. So Robin is NALW, the other way around. I'll pop that in the chat.
Goodness knows where you'll get to with NAWL, Robin. That could be something totally different that we might be completely embarrassed about. Wonderful.
I do that myself, so it's normal.
Okay, thank you so much. We've just got 2 minutes left. So has anyone got any other questions? And honestly, I can promise you that if you find Christiana on Twitter, she will respond, and that enthusiasm will grab you, and you'll have your answer to your question if we don't get it now.
We had one question in the chat from Julie, just saying about where they subcontract social prescribing to another organisation. Sometimes they get caught up in hitting targets and making sure they're achieving their contract. How can they make them more patient friendly?
So let me take that. So, I mean, one of the things that I find is that contractual obligation isn't enough to drive behavior change. So if you even check the movement, how social prescribing came about, it wasn't driven by the contract, it was driven by the GP practices and the social prescribing link workers and volunteers within their community. They realize that something is wrong here and they want to do something about it. Same thing as me as well. It says money doesn't drive me or the contract or all of that. It's the passion and realizing that this is the right thing to do. So it's that actually not putting the fire in them. And this is the reason why this is a value-based recruitment approach, because this sort of role is value-based. So it's not just recruiting somebody that's like, oh, right, okay, I'm a psychologist. I'm not having a go at psychologists, but I mean, it's not just, this is something that is value-based, and to actually get the right social prescribing link, when I guess it. And one of the problems is actually then going and handing them, hello, this is the NHS England contract. No. Some people actually, they've got lived experience, some of the things that they're actually dealing with. They have their own motivation of why they got into this role. So it's connecting that. And that's why some of them that are very community and patient kind of like facing, they're struggling with just the telephone thing as well as the GPs, isn't it? Because when you actually got into a role because of some motivation that you have. So I think it's actually having a chat. Of course, we are using those targets for a quality improvement point of view. Of course, we need to get paid, but people need to understand why they're using these things and why they're having to do it, as well as not losing the patient-centered focus. So it's people understanding their purpose and the vision of what general practice is trying to achieve, what the PCN is trying to achieve, and what the practice, and buy into that vision and understand that these are just quality improvement tools that enables us to make sure that we're doing the right thing. But again, it's quite still very new and innovative, so it can be challenged. If it's not working, you let us know.
So we can challenge with the employing organisation and discuss how that works for you in your practice. Just one last question, and I will have to stop it there because I always promise we'll only be half an hour. What's the difference between a social prescriber and a health and wellbeing coach?
So I see the health and wellbeing coach as the intervention. So the problem we've been having all along is saying a lot of people kind of like lose weight and do stuff, but I haven't got a pair of shoes and them hungry. So now we have got somebody that gets to the root cause of the problem, that makes observation from a social determinants of health point of view. And then if you identify the intervention is by actually losing a bit of weight or wellbeing support, then you refer me on to the health coach. But the problem is that when the health coach is just in title and what they're doing is a social prescribing link worker's role, then there's no difference. But to me, that should be a referral. The social prescribing link worker should be referring to the health and wellbeing coach. And the only reason why the social prescribing link worker's role, it's quite very innovative and it now is a global phenomenon, is because of that social determinants of health focus that it has, whereas a health coach will be looking at healthy eating and all of that.
Okay, so a gateway into that health worker. Fabulous, thank you so much. Really appreciate your enthusiasm. It's got us all fired up for your link worker day. Just before we finish, next week we're talking to Vicky Wells from CQC. Really need your questions for next week. Please do send them to our Facebook or our Twitter, and I've enjoyed spending half an hour with all of you, but particular thanks go to Christy for, as I say, showing us all the enthusiasm and helping us to get that energy for this wonderful, wonderful subject and this great, well, this role within our practices that really can give us a little bit more resilience, and that's what we need. So huge thanks, Christy, and I think you'll have a few more followers on Twitter because I can see that Robin's put your handle in the chat as well. And just a reminder of the things you can do after today for us. Please, if people haven't joined yet, we can only help if you join and pay your £50 subs. Not very much, just to keep us going and keep us doing this amazing work. So we would be really grateful. Go to our website and it will choose membership and you'll be able to join from there. So thank you, everybody. And I'll look forward to seeing all your tweets about our great social prescribing link workers on the 8th of October. Thanks, everyone. Have a good day.
Take care. Bye.
Thank you.
Happy to stop recording now.